Good afternoon. I'm Jana Martin, Chief Executive Officer of the American Insurance Trust, known to most of you simply as the Trust. We're delighted that you're able to join us virtually today for the next webinar in our virtual webinar series. The Trust is pleased to be able to offer this informative content free of charge to our policyholders. Make sure you block time in your schedule for our next Risk Management Roundtable on Thursday, May 21st at 5 p.m. Eastern, and our second telehealth community chat on Monday, May 11th at 5 p.m. Eastern Time. I also want to remind you of the dedicated COVID-19 resources page we created, where you'll find helpful FAQs, downloadable sample consent forms, informative on-demand webinars, and much more. You can find a link to this page as well as the virtual webinar series page on the important information slide. Here at the Trust, we live by our motto, for psychologists, by psychologists. It resonates in everything we do, and we pride ourselves on being able to support the profession of psychology in ways no one else can. Most of you are likely familiar with our risk management consultation service, the Advocate 800 program. It's one of the many benefits our policyholders receive through the Trust. 3 of our advocates are with us today, Drs. Jeff Youngren, Julie Jacobs, and Liesl Bryant. In the interest of time, we've placed their bios on a slide. Before they begin the presentation, I have a few additional things to tell you. First, we hope this will go just as smoothly as our previous virtual webinars, but should there be a technical problem, please bear with us. We'll do our best to keep things moving. If you do happen to run into any issues that you're unable to resolve after using the instructions provided at registration, contact our Customer Service Center at 800-477-1200 or send an email to seminars@trustinsurance.com. As this is an interactive webinar, we will be taking questions from participants. You'll find the Q&A icon at the bottom of your screen that you'll click on to type in your question. Our team will do their best to answer as many questions as possible. Unfortunately, as is true in most any presentation, we likely will not get to all of them. This virtual webinar will earn you 1 CE credit. This can be combined with 5 other risk management credits to save up to 15% on your Trust-sponsored professional liability insurance policy. We'll post a link for the exam in the chat box at the end of the presentation and also provide a slide with instructions. You'll want to screen capture this information if you think you'll need it for future reference. Please remember to submit your CE certificates with your policy renewal. Again, I hope everyone learns a lot over the next hour. Please join me in welcoming our esteemed presenters.
Great. Thanks, Jana.
Thank you, Jana.
Okay, so we're going to go ahead and get started with questions. Sorry, I'm having a small tech issue on my end, but we will work that out in a minute. All right, so we're going to start with a couple questions. And as Jana mentioned, we may not get to everything, but we're going to do our best to get to as many as possible. I know Jeff and Julie are going to try to be succinct while also making sure we get you the information needed. So first question, Jeff, we'll send this to you. The question is, I currently have multiple patients with significant diagnostic complexity, high chronic risk, and increasing acuity. These are not clients I would typically assess to be appropriate for telehealth, and some of them need higher levels of care that I can provide. But alternative options for care are very limited or non-existent at the moment due to the pandemic. What risk management strategies should I consider in management of these clients?
Well, that's a great question, and it's a complex question. Obviously, this is not your run-of-the-mill patient population. But the truth is, the state of affairs in the world right now is the state of the affairs in the world right now. You are either going to have to find an avenue to treat those individuals through telehealth, or find an avenue to see them individually, which we will talk about later on, given an evaluation of the necessity to do that, the risk to the patients, the risk to you. At this point, the trust doesn't recommend that you do that, but that you in fact fall back on the telehealth model as much as you possibly can. We'll talk more about inpatient, in face-to-face kind of treatment, because that's on the horizon. It's obviously something that's going to happen, but for sure it's not something that should just happen. We're just going to do it. There are a number of risk factors that need to be evaluated before one just does that kind of thing. You can only do what you can do, and what you want to do in that circumstance is to make sure that you have engaged in adequate record keeping to support the conclusions that you've done. And we always recommend consulting with colleagues or consult with the trust and get some ideas there, because what that does is it helps establish a standard of care argument. If I do it and somebody else does it, and Julie agreed with it, at least you agreed with it, well, it's hard for somebody to say, well, that was wrong. They can, but it's much more difficult than if I just decide to do it myself. So we encourage a lot of caution now during this time of rapid change. I don't know, Julie, what do you think?
Yeah, I mean, I agree with everything you said. These are the situations where our risk management toolbox becomes really important. So like you already said, document really carefully why you're doing what you're doing. And, if this is someone you wouldn't normally see via telehealth, document why you're doing that and do the best you can. Consult with folks, get some advice. But we can only do what we can do in these current times. And if you have the choice between doing nothing or seeing someone via teletherapy, perhaps you make that choice, you see what you can do. And, if it becomes clear that this person needs in-person services, needs to be hospitalized, needs something else, then you take that step. And you also might want to be a little more explicit about your safety plan. Whenever you're doing teletherapy, you should have a written safety plan. If you know it's a higher risk person, then it may be more important to go over that each time and make sure that you're following your plan and that you have something in place that makes sure that the resources where that client is located are readily available.
Great, thank you. Okay, question number 2. What would you recommend for clinicians who are experiencing burnout and vicarious traumatization and trying to manage both their own reactions and distress, as well as their patients? What guidance can you give for when a clinician might need to take a step back from their clinical work as a result of their own issues? In other words, where is the line drawn? Mm-hmm. And what would one do with their clients at that point? And Julie, why don't we start with you for that?
It's such a great question, and I think it resonates with me and probably everyone. I mean, this is a really unique situation where we are all under the same stressor. Certainly it's different based on your location and your specific circumstances, but we're all going through a collective trauma of kinds here, and we really, as the clinicians, need to engage in a higher level of self-monitoring and of making sure that we're aware how we are doing, looking at our own physical signs, emotional signs, making sure that we notice if we're having headaches or sleep problems or moodiness, self-medicating, overworking. I mean, there's a lot of signs that you can see that you might not be functioning at the highest level or at your typical higher level. And if that's true, then it can impair your judgment. It could cause harm to clients. It could cause an impairment of your competence. And these are all issues. These are ethical issues. The ethics code wants us to maintain some level of competence. And if we are emotionally exhausted and not able to do it, we may not be emotionally competent to do the work. So again, consulting with others, getting a reality check and a gut check from people who know you well, other clinicians, friends, families, doing more intense or intentional self-care activities, making sure that just because you're working from home, you're not working 14 hours a day. You need to set some boundaries and be sure that you can take care of yourself. And there may be a point where you recognize that you need to reduce your caseload or refer folks to other providers. And, maybe you look at that at a case-by-case basis. Maybe just the higher acuity folks are too much for you right now, and reach out to colleagues and see if you can effect a transfer of their care to someone, either temporarily or permanently. But we can't sacrifice ourselves in order to try to help people, because we are not at our best if when we're under this kind of stress, and we're not going to help other people if we can't take care of ourselves first. And I think as helping professionals, sometimes we lose sight of that.
Yeah, I think that the impaired provider question is nothing new now, as opposed to problems we've dealt with in the past, where someone has a client or patient that commits suicide, or they have their own marital difficulties that interfere. You need to listen to the people around you a little bit to see whether there are individuals who are picking up things that lead to some questions about impairment, and then I think, as Julie says, to engage in self-care. And it's very hard to be introspective about your own potential disability and difficulties. But this is not always a stressful profession, but there are times in the profession where it's incredibly stressful. And so we have to honor that you do lose a patient, or a patient kills another patient, or somebody dies of an overdose, or you have your own difficulties in your family. Whatever those things are, they require you to take a look at yourself in the mirror and decide and make some decisions about how to adjust for the struggles that you're in. Or you will damage your clients and patients, and we all don't want to do that.
Right, and I think that's the risk, Jeff, is that we may actually cause harm to our clients, unintentionally, of course. And I think the only thing that, from my perspective, that's different now than is more usually the case is that in times of crises, right, I think we tend to focus outward a lot. Like, there's so much to do, so we focus on our clients and our kids and our spouses and our work and all of those pieces. And in that crisis mode, sometimes we forget to check in. And I think, like Julie said, because it's a crisis and we know, and we're also facing a tremendous amount of stressors on our own, right? I've talked to many callers whose loved ones are actually in the hospital and they're not, they're going to be able to come off ventilators, those kinds of things. That's a lot of stress. And so I think we need to increase the self check-ins at this time, but otherwise I agree with you guys.
For sure.
All right, so Jeff, we'll send this to you first. This is a writer who says, my greatest concern has been how to ethically and legally manage the care of my college students who have been relocated out of my state back to their home states. I have been following the updated information posted by the ASPPB, and some states that their clients are in have temporary practice laws, but those practice laws may soon be expiring, such as after 60 days or after 90 days. So the question is, can you please address the ongoing ethical and legal concerns of choosing to continue practicing telehealth with these kinds of clients across state lines? And the issues are they continue to need care, but they may not even be coming back into the state. These are college students, so they may not even come back in the fall if school is still offline in the fall, right, or online in the fall. And so does the writer says, do I really need to ask them to drive across state lines to have their therapy sessions in their car? So they can be physically present in the state, which may not be possible for some. And also, it may be really difficult for them to find new therapists in their home state. So how do we balance all of those competing tensions? And Jeff, why don't you take that to start?
It's a nice long question, but it's actually a wonderful question. And the question I'm answering now, so I want everyone to hear this, is the question has to do with, you have an existing relationship with a client, a student in a counseling center, who then goes to another state, and you want to be able to see them in the state. And that's what I'm talking about. I'm not talking about doing business, opening up a new practice in the other state, seeing new patients from that state. What I'm talking about is seeing somebody who has moved into another state with whom you have an existing relationship. And it's a great question. So you kind of, I always hate when I practice law because I'm not a lawyer, but you have to understand that a neighboring state doesn't have any jurisdiction in your state. So if you're licensed in California and your client goes to Nevada, Nevada doesn't really have any jurisdiction in California. We, of course, always recommend that you check the temporary practice provisions of the state, and that's listed by ASPPB. They've done a great job with that. But let's just say it's Hawaii, and I don't think the state of Hawaii has a temporary practice permit. What is Hawaii going to do to you in California for continuing to see a student with whom you have an existing relationship, and in our professions, we say over and over, you're not supposed to abandon people, you're supposed to continue to take care of them. My position and the position of many of my colleagues is that go ahead and do that, but keep good records and engage in all that good risk management. But the truth is, Hawaii really can't do anything to you. And we've done this a long time. I've been with the trust 25 years, and interstate practice questions have been with us for 25 years. We know of no case where a psychologist has been criminally prosecuted, because that's what it is. It's a crime to practice in Hawaii without a license in another state. And the reason that isn't going to happen, first, is because it violates our beneficence principle ethically. We have an obligation to do good for the people that we treat. And the second is, and maybe less likely, in order to prosecute you for a misdemeanor in the state of Hawaii, Hawaii would have to contact the Attorney General in California, who would have to agree to extradite you to Hawaii, where they would prosecute you for a misdemeanor. It's not going to happen. It's just simply not going to happen. I'm not saying you should engage in cross-state practice willy-nilly, but in this special case, this is someone with whom you have a relationship, someone that you need to take care of, and you're engaging in good risk management. And the worst thing that's ever going to happen is you're going to get a cease and desist letter from the state of Hawaii telling you to stop, but they still don't have much authority. What are they going to do? They can't come into California to punish you, but the risk is with the California board. That's with whom you're licensed. So we want to create as strong an argument about you were doing the right thing. I understand that at this time of crisis, you violated a cross-state line practice issues. But the reason you did that was based on your belief that this student needed care from you. And you did it this way, and these are your records, and this is why I think you're fine. I think you're fine. And I am not saying that you should just go ahead and practice with anyone you want across the state line. I want everyone to remember I said that. I'm saying in this special situation, you have an ethical obligation to take care of this individual. And I think that those obligations overpower the administrative questions by the state board. Julie, what do you think?
I agree. I mean, whenever I think about this question, I think about the legal, the ethical, and the clinical considerations. And there are times when the ethical and clinical considerations simply override the legal consideration. But what's important is you document the heck out of why you're doing this. Document that you're making, if there is a temporary practice provision in that state, try to comply with it. That's great. If it's the kind of provision like some states have that require you to basically apply to be licensed there and pay a huge fee, and it's going to take a month for it to happen, that's not good enough. So document your attempt to make an effort to comply with that law, and document your belief that the ethics code, the need to ensure continuity of care, the need to avoid abandonment, that those considerations were at the forefront for you, and that's why you took the action that you took.
Yeah, I think that's a really good point, just to beat this to death. There are states, like in Ohio, you have to submit this paperwork to Ohio along with a check for $185 to practice temporarily in Ohio, and it takes a couple of months to get approval. The state of Washington, it takes a couple of months to get approval. Well, your student just left and is living in Washington, and they need to continue that therapeutic relationship. So I would say, go ahead and apply for the temporary practice permit in Washington, but you need to go ahead and see this patient, because as Julie said, the clinical and ethical issues trump the administrative issue of the Board of Washington saying, oh, no, you shouldn't practice here. That's like, come on, that just doesn't make any sense.
Just to add one thing, because I think you guys have definitely clarified, I think, the legal piece of that. But I think the only other thing to think about is what's clinically appropriate for the client, right, in terms of risk. And especially if it goes on for long periods of time, right? So if now it's December of this year and we're still in this situation and they're still far away and they may not be, you want to just be sure that it's clinically appropriate and safe for that particular client. But otherwise, adding those pieces together, I think, right?
Yeah, I don't want to monopolize this, but I think that there's a point, like if you get into December and nothing's changing and your client's living in December and they're in Hawaii and Hawaii doesn't allow you to practice there, you really need to think about transferring the responsibility of this case to someone in Hawaii. You just can't continue with the argument at that point because other things are taking over. And so I would say if it's December, schools are not starting yet, they better, but they're not starting yet, then you need to transfer that case over. You can't continue that rationalization to justify continuing to see that individual.
No, that makes sense. I agree with you, Jeff. Okay, a new question. Is it a liability to provide masks or homemade masks to patients in the office, especially if their masks seemed not adequate? Julie, you want to start there?
I cannot see that as a liability. I think that as we are starting to think about transitioning back into in-person services for some areas where it's safe and where it's permissible, one important thing is going to be to take all the precautions that you can. And we know that medical grade masks are not available. And if they are available, they should be reserved for the medical professionals. And a lot of states are issuing guidance, mine included, that is requiring a mask, a cloth face covering of some kind whenever you're out in public. And rather than a liability, I actually think it's a good gesture. It's a positive thing. It's showing that you're taking every step you can to ensure that you're following those precautions. We want to follow the guidelines that are put out by the CDC. You want to follow the guidelines that are put out by your state. And if you have a mask that you can offer to somebody, if they don't have one, or if they have a giant mask and a little face and it's falling off, that's a way to show that you're trying to be as responsible as you can. You're trying to take those precautions. I don't see it as much different than offering hand sanitizer, right? Someone might have hand sanitizer in their purse, but why not have it in your office? It's an extra way to try to make sure that you're being really mindful and careful and deliberate in how you're going to choose to see people if you choose to take that step.
Yeah, I think that this is better than nothing, right? So, I mean, this is more than zero. And so it's helpful and creates an argument that you were concerned about the welfare of your client. Because as everyone knows, I'm wearing this mask not to protect myself from the client's viral problems, but to make sure I'm not giving the virus to another person. So I think I don't understand how there could be any liability for it. I think that, in fact, if you have patients that you're going to see in person, you need to establish a whole bunch of risk management factors that you're going to import into the relationship that make it effective and make it safer for everyone.
Well, and on that, I'm going to ask a related, I imagine we're going to be getting lots of these questions, so I'm going to try to touch on them if possible, but a related question: how do we handle clients coming into our office if they are not social distancing or if their roommates are not social distancing? Jeff, you want to start on that?
I'm happy. Well, that's actually two questions, though, really. I mean, social distancing with me, that's a requirement. I am not going to see you in my office if you don't follow the rules. I mean, we have rules in the practice of psychology all over the place. We put them in informed consent forms. We tell people the rules. If they don't follow the rules, we're not going to be responsible for that. Now, not practicing social distancing with another individual is a different kind of problem. And I think that you have a right to take care of yourself. First, you need to make sure that that's true. That if you see them hugging and kissing out in the car and go like, well, this is a little bad, I can't do this, then you have really a strong grounds to tell this individual you're just not going to see them unless they follow the rules. And those rules include social distancing with other individuals. This is a serious time. I mean, people are dying from this. And so, many of you know, our son is an ER doc, and you know, he watches people die all the time from this virus. So you need to take care of yourself, and you need to make sure your patients and clients stick to the rules.
Yep, I agree completely. I would just throw in, you know, if you're starting to roll out, starting to see patients again in person, you need to establish what your rules are going to be for your practice. And you get to do that. You get to make the rules. And so, you know, it's no different than saying you can't come to my office inebriated. You're not going to come to my office if you're not practicing safe social distancing or safeguards. If you're not taking those safeguards, if you're, you know, we set up the appointment and you tell me on the phone that you just went to a big party with a bunch of friends, I'm going to decline to see you in person. We have to remember, and we'll probably say this a bunch of times in this presentation, we have a right to take care of ourselves as well. And because a patient demands, I want to be seen, does not mean we must allow them into our space and that we must see them physically in person. So whatever each provider is comfortable with. Some providers may be comfortable with that. And those are individual decisions. And here, we're just here to talk about the risks and consider those risks. But don't feel pressured to see people in person if you're not ready, or if you feel like they are going to put you at risk in some way.
Right. And just to note as well, I mean, and you guys may have said it, but also to put some of those things in writing with your client.
Absolutely.
You know, what you expect of them and what you expect of yourself, what things you're going to be doing to keep them safe, what things you want them to do. And we do have, just to let you guys know, and this might come up later, but we do have a sample informed consent document with some language on that will be coming out in the next day or two. So keep an eye on our website for that, because that will help with some of this language, and it'll give you a clear place to sort of list some of that stuff for your clients so that everyone is on the same page.
Also going to have a list of things you should consider for in-person therapy in a separate document that will be up in the next day or two.
Right.
And really quickly, I'll just one more thing I'll say, and then we can stop this out. You'll see on that sample informed consent to return to in-person services, we leave it as, we list you some options of safeguards you consider, but we leave it to each provider to decide what those safeguards are going to be based on their own review of the guidelines in their state, the CDC guidelines. So we're not prescribing exactly what we believe you must do. We're giving you a bunch of options to consider and things that we think are best practices. And then each provider can look at that and populate that form the way that they feel comfortable and what they think is most appropriate.
Right. And of course, as always, you can consult with us, right? We do, again, recommend a lot of consulting. These are complex issues that none of us have had to face before. So it's always better to do more consulting, not less. Okay, so a couple of testing questions coming up. My colleagues and I are hesitant to pick up new clients. We're thinking about the unique considerations of telepsychology and wonder if you all could comment on best practices for assessment for telepsychology. Now, we may not be able to do all of that because there's a lot of depth in that, but maybe if you guys can give folks just a little bit, like what kinds of things should they be thinking, and or where can they go to get more information on this? What resources would be helpful? And Jeff, do you want to jump in on that one to start?
Sure, I'm happy to do that. That's a big, huge question. And it doesn't just have one answer. It has a lot of answers. In terms of assessment, whether it's children or adults, if you're going to use an assessment instrument virtually or use it in a telepsychology model, you need to make sure that the instrument's validity and reliability carries through that way. For example, there's an article coming out by Yossi Ben-Porth and Dave Corey on the remote administration of the MMPI. And Ashley Pearson has set up so that we can do that. That's different than maybe doing a whisk with the child where you're exchanging objects and it requires person-to-person contact, or you might drop out some subtests because that is difficult to do. Well, that affects the validity of the instrument. So you remember, this is not a time for a license of substandard care. But it is a time for creative thinking and trying to find a way around these things so that we can do assessments, which is a key function of our profession. And truthfully, there are going to be some assessments that are just going to have to wait till we have a better time to do them in a more consistent way. But the answer to the question is kind of like it depends.
Yeah.
And it's not that I'm weasel wording it. It's just really true. Where we have the MMPI we can do it with, We don't know whether you can do it with the whisk. We don't know whether you can use the test instruments forensically versus clinically. What are those differences? Because the incentives are differently. How do you do a disability evaluation versus clinical treatment using an instrument in that platform? It's a time for some real careful thought. I'm not telling you don't do it. I'm telling you, you need to problem solve and have a rationale for why you did do it. And you cannot impact the validity and the reliability of the instrument.
Yeah, and I'll just jump in to say the APA did put out some guidelines for remote assessment. I can't remember exactly how they term it, telepsychological assessment or something along those lines. There's, I think, 5 or 6 guidelines. It's not terribly long. It's a pretty common sense set of guidelines, I think, and it speaks a lot to what Jeff was just saying. You have to consider validity and reliability. You have to consider if there are ways you can modify the administration that would be reasonable. Can you have if you're doing some sort of assessment of a child, maybe you can recruit a parent to help and proctor a little bit, but you also have to be sure they're not coaching or impacting the assessment in any way. So I think if I'm remembering correctly, one of the guidelines was something along the lines of, you're going to do the best you can with what you have. And you might have to get a little creative, and you certainly have to indicate the limitations of any assessments that you do when you write the report. You have to make it really clear if you varied from standard testing protocols and why, and talk about the limitations. When you're not in a room with someone, there's a lot of information missing. I had a caller this morning talking about trying to do mental status exams. And they just felt like the lack of, not being able to see the person walk into the waiting room, not being able to see how they're dressed, see if there's body odor, see if there's, there's all kinds of nonverbals that are really key, especially when you're doing a mental status exam in some situations. And there may be times when you simply can't do the evaluation in an effective way, and you have to recognize that and recognize the limitations. And there's also, I believe we have posted informed consent for teleneuropsychological evaluations on our website at this point, something that Dan Taub worked on. So if you're going to do this work, you do need to have an informed consent that's really clear about what you're doing, just like you always do with assessments, but there is a different element to it when it's a remote assessment. So your informed consent needs to address those different elements, needs to address that you may not be able to come up with as strong recommendations as you might. You might have to, things might be less clear and your recommendations may be a little bit, a little fuzzier because you don't have the advantage of being in person and doing the standard administration. So informed consent is another really important piece of all of this, when you're doing teleassessment or teletherapy, to make sure that you've addressed those additional risks and additional considerations, and that your clients and patients are online with that.
Yep, and I'll just add, because we have another question here on doing forensic assessments in particular, and we won't go into each of the distinctions for all of these, but certainly, again, not to just, sound like a broken record, but consulting, and in particular, consulting with folks doing those. So if you're, forensic evaluations, consult with the forensic diplomate folks, right? The board certified folks. If you're a neuropsychologist, consult with, those groups. You want to look for resources put out by those organizations as well, or groups. Because, on the one hand, yes, we can state in a report that our findings are limited, but depending on the context, some forensic evals have very high liberty at stakes, right? Like death penalty evals, things like that, child custody. So we do have to be careful. And there is a line where we shouldn't just do the eval and say, oh, it might be limited. We might need to think maybe we don't do it right now. So again, there's no black and white answer, this when you do, that when you don't, but consult, look at resources. I know there have been some CEs done. Dan Taub did one with a number of other groups on neuropsychological assessment, in particular via telehealth. That may be on our site, I'm not sure, but take a look, try to find resources, and then consult. Right? Okay. So this is actually a question we've gotten, I've actually gotten a fair number of calls about, so we'll add this in. Should I put an auto reply on my email that says, if you have a mental health emergency, please dial 911? I've found that in order to do telehealth, I have to email the link to patients. I put a statement in my telehealth informed consent that email should only be used for administrative purposes, but I'm worried about patients abusing it and sending provocative emails. And then I've also heard that people are concerned about referring people to 911 and or to emergency rooms due to risk of the virus. So what would you guys say in that regard? Jeff, do you want to start?
Is that one mine?
Yeah.
I was losing track of the order here. So I am an individual who is, over the years said, just use email and text for administrative reasons. Stop engaging in these personal relationships with individuals in email. It makes it's just not healthy. But now it's interesting because we now have telepsychology, and that's kind of a virtual shift for us to kind of something to which we have to adapt. I don't think there's any downside for putting in any document, if you sense that there's an emergency, please hang up and dial 911. I mean, that's on every doctor you call tells you that now. And why is that? Because it's just risk management. You're telling them what to do. Can you make them do that? No, you can't make them do that. But you are trying to exercise and demonstrate responsible duty to the care of your client or your patient in doing that. I don't, emails or texts, like stop all of this personal interaction with people in texts and email. Use it for administrative reasons. Say if it's a problem, dial 911, and then limit your contacts to telephone, telepsychology, or to face-to-face practice when we get back to that.
Great.
Yeah, I agree with that. And I think, it sounds like this particular question is, they're concerned that people are going to abuse that perhaps email and send something that is, I'm in crisis, I need help now. And the idea is when you get an email, immediately you get an auto response that says, thank you for your email. If you are experiencing a crisis, please call 911, or if there's a talk line or something that you have in your area. I think that's not a bad idea. It gives, it can help you, if nothing else. I actually did something similar when I was practicing. And at the end of the day, when I was done responding to emails, I turned on an autoresponder every day that said, thank you for your email. I will not respond to you before the next business day. And if you're in crisis, call 911. And that way I didn't have to worry about what was sitting in my inbox all night. I didn't have to wonder, did someone send me something and I needed to tell them to seek help or to seek, to call 911. That already went out. Now, like Jeff said, they may or may not pay attention to it, but if it gives you some peace of mind, I don't really see harm in doing that. And I think there might be some benefit in doing that.
Correct.
Great. So this one's on a different topic. What do I need to consider in having my students do remote video groups in an acute psychiatric hospital? Julie, you want to start that?
My goodness. So I'm assuming this is a supervisor asking about their supervisees or their trainees doing groups. Well, I guess the benefit is they're in an acute psychiatric unit. So, if there's something going on, if there is some kind of risk or some kind of situation, they are someplace where there's going to be help and there's going to be the situations they need. I mean, supervision is always risky. You always need to be really on top of what your supervisees are doing, and you need to feel comfortable with what your trainees are doing. And so, you may need to be a little more available than usual, and you may need to talk to them about some of the things they need to consider in doing a group like that. But I actually feel, I like the question because they're already inpatient. So there's going to be something there. I mean, the things that come up, the concerns that come up are, how are you going to manage a crisis? How are you going to manage it if things get out of control and you're in a different situation and there's no one there to manage it? Here, it's sort of a contained situation. So maybe the risk is a little lower. But as always with a supervision situation, first of all, make sure the trainee, the student, is comfortable doing it, and that you've given them guidance and that you're very available to them to consult with if something does go wrong in the meeting and they're not quite sure how to move forward.
Mm-hmm.
Yeah, I think one thing that's to be sure to pay attention to the reality that you're responsible for the conduct of your supervisee. Mm-hmm. It's a licensed professional. They make a mistake, you're responsible for that. I do believe that virtual communication like this, Zoom, is an okay way to supervise, but you need to discharge the obligation to protect yourself and your own practice from the mistakes the students have made and make. And there's another issue that you need to check out depending upon the state you're in, which is, will the state accept virtual supervision in the first place? Will those hours count? And everybody kind of wants us to know what every state says, and it's kind of impossible to do that. So you need to check out with your state how they've adapted, or the state where the client is or where the supervisee is, if they adapted so that those hours even count for licensure. That's an administrative question, not a clinical question, but it is an important question. And the point I'll say again is, supervisors should always remember that they are responsible for what happens. And so they need to keep their eye on that responsibility.
Mm-hmm. And I'll just throw in real quickly, something I've noticed as I've been doing calls over the past few weeks is a lot of the state boards websites are actually quite helpful on this. And they will have buttons right on the front page that says waivers related to supervision, waivers related to teletherapy,
Yeah.
and they're giving guidance about what's changed. So it's always worth taking a trip to the state board website and see if they do have some resources up there that talk about that supervision issue and whether those remote supervision hours would be permitted.
Great. So here's a question. It's very quick, so I'm going to give the answer. It says, will trust consultants be available to review trust member consent forms? And the short answer to that is no. If you have a particular question, you can call in and get consultation about a piece or a sentence or a little, that kind of thing, but we can't review the entire form for everyone. What we do, certainly, like I say, if you have questions, call in, we can talk about small pieces, but we do recommend that if you develop a consent form that you have your own attorney review that, just to make sure you're in compliance with state law as well. So, okay. When I send intake paperwork to new patients who I am seeing for the first time over telehealth, does the way I send and receive back the paperwork, for example, DocuSign, need to be HIPAA compliant? Jeff, I'm not sure who we're on, so Jeff, you dive in.
It's a toss-up question. Does it need to be HIPAA compliant? That's a really great question, and the non-lawyer in me will answer it. That under HIPAA there is an exception for entities that are conduits for protected health information. So if you transmit something from point A to point B through Verizon or whatever, and they retain no copy of it, they are considered a conduit. And so you do not have to have a business associates agreement from them in order to do that. So, but if they do keep a copy, and what's interesting is the DocuSign question, DocuSign does keep a copy of those documents. So you need to get a BAA from DocuSign if you are going to use that for the verification of signatures, which is an interesting question anyway. Do you need a secure signature in the first place? And I would answer, no, you don't. You just need to know that the client signed it and have some record of that. So you're seeing a client, you give them the informed consent form, you go over the informed consent form with them. I recommend that when you do that, they need to sign it. When they sign that informed consent form, there are many ways they can send that form to you. They can take a photo of it and email it to you. They can send it through their cell phone to you. That's fine. That works really well. You've gone through the phone and through the record with them. They've signed it, and then you put in your chart note what you did, which is, I went through this document virtually. Martha signed it. I have a photo of that signed document, and you put that photo in the record. You don't really need a digital signature, which is not cheap. You just need to make sure that you have a signature.
Yeah, and I think, something that people get confused about sometimes, the informed consent, the blank informed consent that you send to somebody, that's not PHI, that's not protected health information. That's just your informed consent. So you can email that to them in a non-HIPAA compliant, unencrypted email. It's just the form. So send them the form in whatever way they can get it. And then, like Jeff said, there's a variety of ways you could have them have it in their hands and show it to you and sign it in front of you at that first session, fold it up, stick it in an envelope and send it to you. You will have had the conversation with them, document that you went over it with them, you saw them sign it. And yes, it shows up a couple days later, but that's a pretty good way to manage it. Or like Jeff said, have them take a picture. There's a lot of different options, but the blank form itself, that's not PHI. That's just your intake paperwork. And that's why you see that a lot of times, a lot of providers actually just post that on their websites. It's just a form. So you might have to get creative. You certainly will have to get creative. And sometimes, one concern is if it's easy for us to say, print it out, sign it, scan it, send it back. Well, not everybody has a printer. Not everyone has a scanner. But if they have email, they're able to receive that email from you. And in the worst case scenario, you're going to go over it all with them verbally and have them, assent to it and you document them. Or you mail it to them in the US mail. And then, like I said, at that first session, have them take a look at it, sign it in front of you, send it back to you, and then you'll have a copy of it.
Yeah, I mean, there's just so many ways to get evidence of that. Also, I think your intake forms are not PHI either. You send those as well. So they fill out the intake forms and they use there's a program called Cam Scanner that you just take a picture of it and you send it by email to you. Doesn't need to be HIPAA compliant. There are just lots of ways to have this work out very easily without a lot of inconvenience. But you have to think about it.
All right, thanks. We are gonna keep moving. This one I think does come up in different ways for different people, but it says I am doing brief check-in sessions with nursing home residents over the phone. Many of them are less than 20 minutes long because the residents are very elderly, cannot hear, etc. Is there any way I can bill for this and any assessments I could use? These are residents I know already. So any tips on nursing home? And Julie, do you want to dive in on that? Or?
Well, I think really the billing question, a lot of that is going to depend on who the insurer is and what their requirements are and what they're willing to reimburse for. I mean, I think Medicare did recently start to say they're going to be covering phone sessions. And this doesn't sound like an actual phone session. It's more of a check-in, which I think is something that was reimbursable by Medicare and under some circumstances anyway. But you'll need to check with the insurers and see what they're going to cover and what they're going to reimburse and whether that's something that's allowed. Excuse me.
Yeah, it's a great answer.
Right. Okay, we have a couple other questions here again on going back to the face-to-face. So I know we've talked about that a little bit, so we don't want to go through it a lot, but maybe can you just give 2 or 3 quick pointers on if a clinician is in a state that is reopening, how do they decide? Do I go back to face-to-face sessions now or not? How, like just a couple of things, like what are the main things I need to think about to make that decision? Beth, do you want to jump in on that first? Or?
Happy to do that. I think that when you take a look at our document on the website in the next couple of days, it'll point out the things you should consider in restarting face-to-face therapy and making sure that the environment is safe to your client, and having clients not run into each other. We were always worried about that before, not kind of anyway, but now you know that a client comes in 15 minutes after the last client was finished, so that and you engage in making sure that that environment is as sanitized as possible, and I think it's probably a good idea to have that as a written policy so that your patients and clients understand what you are doing for them. And I think that's going to be part of the informed consent, just to say that these are my obligations to you. This is what I'm doing, and this is what I won't do, and then we really make sure that there's a record of that, because that as we've talked about for years, you know, if it isn't written down, it never happened. And so you make sure that you keep the record and make sure that the client is aware of those rules and that they agree. And there will be a list of suggestions, you know, social distancing, I'll wear a mask, we're sanitizing the office after each person comes and goes. Those are the kinds of things everybody's doing it, right? Why wouldn't we do it? I mean, rent a car, they sanitize the car. You know, you get on airplanes, they sanitize airplanes. You need to sanitize your office.
If you're going to do it, right?
Yeah.
Okay. So here's a question. What are the components of a written safety plan for telehealth? Julie, you want to dive in?
Sure. I think, you know, the one important thing is going to be you need to identify resources where the person is located, right? So if you're doing telehealth, you know, let's say you're a provider, excuse me, you're a provider in Denver and your patient is in Denver, well, great. You're going to know what the resources are. You want to develop a plan of, you know, who would be the first person to call? Is there a contact person? Is there an emergency contact that the client is willing to allow you to reach out to? Establish who that person is, get their contact information. Are there mobile crisis resources? Are there crisis walk-in centers? So just becoming aware of what resources are available. And again, it might need to be a little bit modified because of the current situation. So a mobile crisis resource might be great. You could have someone come to a house if someone needed that. Having a contact person in place is great. You also need to confirm the location of the client at the beginning of each session, because just because you have their home address and you know what their resources are and where their contact person is, they sign on to a session, they might not be home. They might have gone somewhere. So a quick check-in at the beginning of the session to say, are you at home? Are you at the address I have on record? If not, let me know where you are. And then you're going to know a little bit better, how to direct resources to them if there is some kind of crisis or situation. It's not that different than the safety planning we do anyway. It's just a matter of, if someone has gone to a vacation home to hole up somewhere nice and they're a couple 100 miles away, what resources are there? So I'm in Colorado, so I think about folks who went up to mountains. There's a lot fewer resources up in those mountain towns. So you really need to know if there's not going to be a hospital or a crisis center of some kind, what are you going to do? Who are you going to reach out to? And how are you going to make sure that that person can get the help that they need if there really is some sort of crisis?
Great, thank you. Great answer. So this is a question from a little bit further down, but it goes back to what we were talking about a minute ago. And we've actually gotten a lot of questions about this. So I'm going to ask you guys to speak to it. It's related again to the going back to the face-to-face. It says, realistically, in some demographic areas, the risk of exposure is extremely small. Risk management is important, however. However, the generalized emphasis on covering ourselves legally is overwhelming our attention to the emotional, mental health of our clients. How can we strike a better balance? Jeff?
I think that's a really fair question because in the middle of Montana doing therapy is different than in the middle of New York City. It's logical that the care and the risk management you need to do in Montana is probably less. That said, how much risk are you going to take, right? I mean, there are cases in Montana, there are cases in eastern New Mexico. I think that you need to stand back and I think also consult with colleagues about, well, we're in Montana now. What are the things we probably need to do given the reality that the expression of the virus is very low here, and implement those with some eye on the actual risk. But I am not saying don't do anything. I'm really think because you're just in a low risk state, doing nothing is asking for a problem. Because everybody else in all of the commercial world is doing the things that you kind of don't want to do. And so I do think that you need to have, maybe less dramatic of a plan, have to have something there that recognizes the risk. I don't know, Julie, what do you think?
Yeah, I mean, I think that you absolutely need to consider where you are and what level of infection is going on where you are. And that's one of the list of considerations that you think about. But doing nothing is not an option. Business as usual today for me is not an option. I don't care if you're in a low transmission area. I just feel like there has to, what you don't want to be is negligent in reopening your business. What you don't want to be is putting people at unnecessary risk. And so maybe you don't need to engage in face coverings, but you sure should have some hand sanitizer, and you sure shouldn't be necessarily hugging or shaking hands or having physical contact with people. I mean, there are steps you can take. And, I just want to throw out there, we put out these documents that are guidance, and they're risk management documents. They are by nature very conservative. That's the nature of risk management. So you look at our guidance and understand that those are our considerations. Those are the things we're thinking about in terms of risk. And then you make your decision. You do your risk analysis and you figure out what makes sense, knowing what you know about your area. I mean, if you're in a location that has opened up completely, I'm not sure anyone has opened up completely, but if you're no longer at stay at home, but you're at safer at home like we are here, things are a little bit different, and things will be different in a few weeks. They may get worse, they may get better. You need to keep an eye on what's going on in your area on an ongoing basis, and you may end up deciding to open next week, and a month from now, you decide that you can no longer stay open because conditions have changed in your area. This is a very dynamic situation. No one answer is going to be right for everybody. And it's really a matter of looking at those factors that we outline and the factors we outline, again, none of this is gospel. These are things for you to consider and to weigh in your mind, knowing what you know about your area and your own personal risk. If I'm a 75-year-old therapist, I'm probably not going back to do in-person therapy. It seems unsafe to me, but there are just a lot of factors, and it's a really dynamic analysis that you have to engage in.
And I think one of the things you don't know is what the second wave of the virus is going to be like, or the third wave of the virus is going to be like, and you don't want to be found wanting at that time. So the risk management advice is dynamic, but take a look at northwestern New Mexico with the Native Americans, a huge viral outbreak there, and no one thought about it a few weeks ago. So it's not all just safe, but you adjust your risk accordingly.
Yeah, and I want to just speak for a second to that idea that we're covering our own tail, so to speak, that risk management is only our own liability, which is not actually true. The best risk management, and I think all of us here would agree, the best risk management is actually the best clinical care too. They are actually one and the same. So we're not sort of covering our own liability. I mean, I think it's critical that we think about our patients' well-being and emotion, and that there is a balance of that. That is good risk management. But for us to be thinking about how do we keep our patients safe, what precautions do we need to take, that's not just covering our own tails. That's actually doing the very responsibility that we are required, and I think most of us want to do for our clients. So I just want to caution, I think sometimes we get in that mindset that if we're doing risk management, that means it's only about covering our own tails. And I think that's a real misconception.
I entirely agree, Lisa. I think Bob Woody's done a lot of writing about this, that, risk management is in the best interest of the consuming public, of the client. It's not that you're just avoiding getting yourself into problems, but you're trying to avoid the client coming down with COVID virus.
Right. We are avoiding harm. It's our ethical duty to avoid harm. Yeah.
Exactly.
Right. So we have just about 4 minutes, so I'm going to see how many questions we can get through, like a flash round here. Jeff?
One.
I'm more hopeful than you are. We'll see. Okay. Let's see. I had a patient I saw on FaceTime. An hour after the session, he texted me that he had recorded the session and asked if that was okay. I told him it could lead to HIPAA issues, and also that teletherapy should mostly approximate the in-office experience, that it could affect what he might choose to talk about, etc. Any ideas in general on this? FYI, he does not presently tape the sessions, which is good. Julie, you want to jump in there?
Yeah, it's a really nice thing to put in your informed consent form that the client is agreeing not to record the session. It just changes the dynamic, I think. And, yes, security concerns, and also just, it's a different feeling if you feel like it's something that you can agree upon ahead of time. That doesn't mean they're not going to do it, but they will have explicitly said, you're setting that expectation, and hopefully they'll respect that. And then if you find out they did record it, then you can say, that's a violation of our agreement, and you can consider whether you want to continue with that or not.
Yeah, I think people have recorded sessions forever. Sometimes there are therapists who allow clients to record them and take them home. I understand, that there are PHI and the risks with that, so you have to cover all that. For me, that question says you've got a problem in your relationship with your client, and you didn't set up the rules beforehand. So you've got a problem with yourself too. You just need to come to an agreement about what is and isn't okay in this virtual world. I mean, it's like having someone sit in their session with them, right? They're in the room and you're doing the teletherapy session. They may think that's fine, when in fact that might create some real privilege arguments under the law. Because if someone else is present, that then makes the relationship, the communication not privileged in most states in this country. So that has to be kind of ironed out before.
Right. All right. I am going to fit in one more, Jeff. Can you do an intake over the phone versus video? So, Jeff, do you want to jump in? All right, you take it. Can you do an intake over the phone versus video?
I mean, I think it depends on if you think you can do an intake over the phone versus video, right? I mean, do you feel like you're going to get the information you need? And, you're certainly going to be missing some information, but there's also, I've heard some interesting arguments, and I won't go too far, but there are some people who actually say you can get more from a phone call because people are focused only on, you can hear voices, you can hear expressions, you can hear things that you might miss when you're trying to interpret all this video stuff. And it becomes, in some ways it can be more effective. Now, certainly that's an individual decision. You're not required to do that, but I think it can be done.
I agree. I agree. Is it going to be enough for you? I mean, is that, and are you passing up a better way to do it? If you can do it better, then why would you do something?
Try.
Why use a telephone when you could use a video and then you can actually see them and see their mannerisms and whatever. So it's how much is enough? It's up to you as a clinician, and you're responsible for that. You know, that's the trade-off.
One more thing, I'll just jump in, document why you did it if you did it. So, you know, maybe they didn't have access to video and it was better than nothing. So document, document, document. That's always a good strategy.
Right. So that's a perfect note to end on. Remember the risk management strategies: consult, informed consent, document. And at that note, I'm going to turn it back over to Jana, who is going to tell you about how to get your CE. So don't go away. In just one moment, you'll see a slide for that as well. So welcome back, Jana. I'm going to turn it over to you.
Thank you. And thank you all for a very stimulating and interesting discussion as usual. We've had many questions about where can some of the documents that were referenced be found, and they are on the trustinsurance.com website. There's a nice little banner box that says COVID-19 resources. There's the virtual webinar series link and several links that are here as well. So now let's talk about how you can get your CE. So hopefully you see in front of you the directions. You can also go into the chat box and find information and a link to take the exam. So go to this link and you'll be prompted to enter your CE account username and password. If you don't have an account, don't worry, you'll be prompted to create one. It can be done very easily and very quickly. It is important to note that your CE account credentials are not the same as your insurance policy credentials. So if you try to sign in with those credentials and password, or the one that you have maybe with our Beacon Live productions, that's not going to work. If you've forgotten your password to the CE account, you can reset it and check your spam filter for the reset email. After you've logged in, select the Take Exam button. You need to score a 75% or higher to pass. You can leave the exam and resume later. Just log into your CE account page and look under My Continuing Education to resume the exam. When you're finished with the exam, you'll be prompted to fill out an evaluation. Once the evaluation is complete, you'll be redirected to a page where you can download your certificate and view your answers. You'll earn 1 CE from this event that cannot be combined with other risk management credits to save up to 15% on your trust-sponsored professional liability insurance policy. And as always, remember to submit all your CE certificates when you renew. We're going to leave this slide up on the screen for a while. Remember, there's also information in the chat box, which should be at the bottom of your screen. But at this time, the presenters and I are going to leave you. We hope that you will come back and see us in our next webinar series, which is Thursday, May 21st at 5 p.m. Eastern. And don't forget our second telehealth community chat, which is Monday, May 11th at 5 p.m. Thank you very much, and goodbye for the trust. Be safe and be well.